what I would like to do tonight is introduce two ladies, Dr. Fernanda Almeida and Dr. Nelly Huynh. The topic is the future of oral appliance therapy. You have their bios, but in case you couldn't read the fine print or didn't take time, let me quickly read the bios for these two ladies. Dr. Nelly Huynh, who will be speaking first, is a PhD. She was a student and then an employee at the Faculty of Dental Medicine since 2000. Nelly has been an assistant professor under grant since 2011 in the Department of Oral Health at the Faculty of Dental Medicine at the University of Montreal and at the CHU Sainte-Justine Research Center. After having completed a doctorate on sleep bruxism under the supervision of Professors Gilles Lavigne and Jacques de Champlain, she did specialized training on sleep apnea, pediatric sleep disorders, and magnetic resonance imaging at Stanford University, California, as well as training in global health, epidemiology, and research in international health at the World Health Organization in Geneva, a group that we've heard lots about. Regarding Dr. Fernanda Almeida, she received her dental surgery degree, her DDS, from the University of Sao Paulo in Brazil in 1995, and in 2000, her Master of Science from the Federal University of Sao Paulo, Brazil. She is an alumna of the UBC, which is British Columbia, where she completed her Doctor of Philosophy in Dental Sciences in 2005. Dr. Almeida has been involved in oral appliance research and the treatment of patients with obstructive sleep apnea since 1996, and her research is focused on oral appliance side effects, compliance, titration modalities, imaging, and treatment outcomes. With other UBC dentistry faculty, Almeida has designed an interdisciplinary program in dental sleep medicine for the clinical specialty graduate programs in orthodontics and pediatric dentistry. She's also a member of the executive board and research chair of the American Academy of Dental Sleep Medicine, often referred to as the AADSM. So ladies, we welcome you. I know it'll be a bit of a challenge because you're sharing the time, but we flipped a coin and Dr. Huynh is going to begin and she'll be followed by Dr. Almeida halfway through. So thank you for attending, and all mics are muted, and Dr. Huynh, it's all yours.
Thank you. Let me share my screen. And there, does it work?
Yes.
Perfect. So first, thank you so much to the Academy for inviting both Fernanda and I to talk, especially tonight when there's a hockey game. So as Canadian, we know it's a
no pressure, no pressure.
No, I know. I'm competing with the Stanley Cup. It's hard. But thank you for spending a bit of your time with us tonight. And so the topic that was given to us was the future of oral appliance therapy. And I'll start with pediatrics, and for Dr. Almeida would continue on with adults. So I just wanted to start with conflict of interest disclosure. For the pediatric part, I have none. And for the only one that I do have is that for the adult parts that Fernanda will share, we do have some of the oral appliances that were provided to us in kind for these research projects. So in dental sleep medicine, one of the first things that we look at is the craniofacial morphology in pediatrics obstructive sleep apnea. And so what we know is every craniofacial features that constrict the box around the upper airway are risk factors for obstructive sleep apnea. So anything that constricts the box anteroposteriorly, so such as the retrusive mandible or retrusive maxilla, or also the adenoid face, what we usually call that long, narrow face. So a longer lower third, a constrictive maxilla with a high arch palate. And then the other factor, other craniofacial morphology that we see is that opened cervical mental angle here at the under the chin to the neck angle. And that also underlies the position of the hyoid bone. And so most of the studies that have been published are actually mostly done within dentistry or ENT. So there might be a selection bias from these studies. So from these craniofacial features that we know are risk factors, what have been published as that the oral appliances in PEDS OSA is anything that can open up that constricted box. And these are orthodontic appliances. And so they are used during growth of children, and we actually guide bone growth, and it has a permanent effect. And so there's two types of these orthodontic oral appliances. So those who open up on the transverse plane, so maxillary expansion before the palatal suture closes up, and the mandibular advancement like adults, but we're actually trying to guide the mandible growth towards the front. You can see on your left-hand side the maxillary expansion studies where they looked at pre and post oral appliance treatments with PSG. So they actually did diagnose obstructive sleep apnea before starting the treatment and not just during the treatment because they had a few symptoms. And then on the right-hand side are mandibular advancement appliances that were used. So these orthodontic appliances are actually fixed. Some of them can be removable. So we don't usually have the same level of treatment adherence issues that we have in adults. And you can see in your expansion treatments that most of them reduce the AHI post-expansion, but you do see some persistent respiratory event post-treatment. So the horizontal red line is your 2 events per hour in kids, and you see that there's a few studies that still have post-treatment some respiratory events. In the mandibular advancement oral appliances, there are less studies, and you do see that they all seem to slightly reduce to different levels, the reduced respiratory events, but there's still also in some studies some persistent sleep apnea events post-treatment. So the current evidences showed that it's an interesting and potential treatment for the management of obstructive sleep apnea in children. But there are some caveats to these evidences. First, they're clinically heterogeneous studies. Some of the kids have or have not had surgery, for example, or not have some overweight issues, weight issues. And some of the studies, when they do the sleep study post-treatment, the devices are still in place. Just because some of the treatments, we need to maintain that position for a while to make sure that bone growth is there before we remove it. So that's maintenance phase. And so the sleep studies done with the oral appliance in place versus when we remove it, the AHI will be different. And actually one study with Pirelli actually said that once you remove the oral appliance, you increase the oral cavity space, and then the tongue will take back its natural position, which is roof of the mouth and anterior position. So that might change the amount of posterior collapse during sleep. And the other caveat is that only 3 of these studies actually reported on non-responders to treatment. So obviously they all show that average of the groups, but very few studies actually go into clinical details of those non-responders to treatment. And we know that for all treatment, you will have some that don't respond. And so I looked at the numbers, and what we saw is that 15 to 47% of them were actually stationary or worsened in their AHI post-treatment, and 58 to 93% actually had residual AHI post-treatment. And this very important clinical information is not always reported in the literature. So Dr. Almeida and I teamed up and created the Pediatric Dental Sleep Apnea Project, and we were interested to look in Canadian kids. And we were interested to see craniofacial morphology in these kids, but who would benefit from oral appliance treatments as children with obstructive sleep apnea. We also wanted to look from the more general population with sleep apnea perspective and not from the dental or ENT perspective. So because, as you all know, there's not as many pediatric in-hospital sleep labs compared to adults, we combined forces with 4 sites. We were Vancouver, Calgary, Toronto, and Sainte-Justine in Montreal. And you can see the names of some of our great collaborators. And it took us a few years to get 400 kids, over 400 kids, because a lot of food lab are busy with craniofacial syndromes or neuromuscular syndromes or in-hospital kids. But we managed to get them, and their mean age about 9 years old, and about half of our sample had an HI over 2. And what we found was that the different risk factors, such as being boys or weight as obese or overweight, were not significant in our sample. What came out significant, which was not surprising, was having large tonsils, which is 3+, 4+ combined, in our group with diagnosed with sleep apnea, 30% versus 20%. And when we looked at craniofacial factors, we didn't see anything specific that kind of popped out. Everything was balanced between both group with apnea versus without apnea. And that these craniofacial features that we measured in these kids, it was very similar to what we would see in a general population. So no clear subgroups of kids that could benefit from orthodontic oral appliance treatment jumped out from our sample through the just general sleep practice. So because the large tonsils came out significant as a risk factor in our specific sample, we were then interested to look at our ENT clinics. And we looked at the ENT clinic in Montreal. We have a database of over 4,000 kids that had TNA about an average of 6 years ago. And we sent them surveys to look at self-reported OSA symptoms. And for those who had persistent OSA symptoms, we invited them for physical and dental assessments, and then also a level 3 sleep study. And what we found was that about 40%, nearly 40%, self-reported having symptoms a few years after surgery. And from the sleep study, nearly half of them actually had persistent obstructive sleep apnea. Most of them mild, maybe a lesser degree, 20%, with moderate to severe sleep apnea. This was mostly associated with being a boy and being mouth breathers. And we did see from our overall sample that most, those who were operated at a younger age for their TNA, they were most likely to be male, of Black ethnicity, and have a convex profile, which means that the mandible was more backwards compared to the maxilla's position, more retruded. And we also calculate the sleep clinical record score, which is a score published by Mary Piavilla in 2013. And the score was significantly associated with the respiratory event index. And the score, we used it because for us, it felt like it was the more complete, because it had, of course, tonsil size and body mass index, but it also had some craniofacial features in the score and symptoms, and 4 types of phenotypes. So these are the 4 phenotypes that are part of this score. And soft tissue hypertrophy, of course, were post-surgery. We didn't have any obesity in our sample. No direct association for craniofacial features, that we did a full orthodontic workup. But we did see that a narrow palate had a tendency to be associated with a higher respiratory event index in this subgroup. And then the 4th phenotype listed by Villa is the breathing dysfunctions. So it's that more oromotor function. And the tongue motor imprecision was significantly associated with respiratory events. And this is just simply asking the child to open their mouth, to, with the tip of the tongue, try to touch the roof of their mouth. And so a lot of our kids were not able to do that accurately, and some were just not able to do it completely. And so from what we saw in the sample is that we might have a subgroup that may benefit from oral appliance as an adjunct treatment following TNA. And this is not necessarily right after TNA. These might be a few years later as they grow. And then also breathing exercises like myofunctional exercises or speech therapy exercises that may be also an adjunct therapy for a subgroup of patients that do have persistent sleep apnea a few years after TNA. And the last piece of our puzzle that we had, and we were hoping to get the answer to, is to look at the natural history. So which kids would actually benefit from oral appliance over the years as the OSA changes, the course of it changes over the year, and who would go into remission versus who would have increased or new obstructive sleep apnea as they grow older. And there's a few natural history studies that are out there. This was the Cleveland cohort on your left-hand side. They took between childhood and teen and their adolescence years, 8 years later. And for us, we took them from childhood and 5 years later, early adolescence. Unfortunately, COVID made us have a hard stop, so we were only able to recruit 19 patients. But basically, the Cleveland cohort and our cohort, we see that the incidence of obstructive sleep apnea between childhood and adolescence seems to be similar, but the difference is that there are different players coming in and out of obstructive sleep apnea. Some have a remission and some have a new occurrence of obstructive sleep apnea as they grow older. And in the Cleveland cohort, their conclusion was that probably the incidence of obstructive sleep apnea in adolescents is closer in the pathophysiology to what we see in adults. So from our sample, we didn't see any significant craniofacial risk factors. We didn't see who would go into remission, who would benefit from having an oral appliance as they get older and as obstructive sleep apnea appears, just because we had such a small sample of 19 patients. So we really couldn't make any conclusion from that, unfortunately. So this is my last slide before I give the floor to Dr. Almeida. For pediatrics, the future of oral appliances is that, of course, a craniofacial morphology that we assess in dental sleep medicine is still an added variable to create within that perfect storm for sleep apnea in children, but it's definitely not alone, and it might not be that first big variable in itself. It's just that added variable. And we can see that in adults, it's been reported about 96% of patients have multiple sites of obstructions. And this is something that we probably can translate over to kids. It's just not just the constricted box, but there's other factors that can play into it, such as the form and the function that we shouldn't forget. And so the importance, from what we've seen in our experience in our different studies that we've done, is that we need to have that continued strong collaboration between physician and dentist, especially in kids. We really need to be able to collaborate and identify those potential responders to oral appliances with obstructive sleep apnea, most likely maybe post-TNA, those more severe cases that do have that constricted palate or that very rectomatic. And to also ensure follow-ups to make sure that there might be multi-treatment and there might not be right away when the kids are the most symptomatic, but maybe 5 years or 8 years or 10 years down the line as their growth changes, their weight change, their puberty hits, and they might need other types of treatments to kind of control and manage their obstructive sleep apnea. And as a researcher, of course, I have to say that for dental sleep medicine, the important thing is not only to look at form, which is the specialty in dentistry, right? Just to look at that box, look at that craniofacial form and look inside the mouth, but also never to forget that function side of things. And that is, I think, the most important in the future of oral appliances use in pediatric sleep apnea. So I will close my screen. Let Fernanda continue in adults.
Okay, thank you, Dr. Huynh. I think Dr. Almeida is standing in the wings.
I'm passing the puck over to you, Fernanda.
Yeah.
For the win.
Okay. Yeah, there we go. There we go. I'm here. Not a problem. So thank you very much, Nelly, for the great introduction. And of course, thank you, Mark and David, for inviting us both to be here with you all today. And thank you for those of you who are here live. I'd much rather see some of you rather than you all just listening to me a week later, so we can get some interactions and we can talk and ask questions, which I always find the most interesting is, and it's where we most learn. So of course, I did expand a little bit. Nelly did put in mostly oral appliance, but I think it goes beyond oral appliance. So as Nelly is saying, is really dental sleep medicine and what we're looking at it in terms of the future and what we have to go from there. As Nelly said, I also do not have some conflict of interest. We do have some funds. Many of them are together with Nelly. And from some companies, we have received appliance and monitors, but they have no rights at all over our studies. So where are we leading? Where is the future? And I think whenever we talk about that, we want to, especially right now with COVID and things, we are looking at the world and how are things going beyond our own country. And what we know is that the prevalence of sleep apnea worldwide is increasing with obesity, and it is increasing also with the time that we're learning more and more about the disease and how to diagnose. So I think with all of that, it is a major issue. So we know in terms of obesity per se, 600 million people are obese. Okay, so it is really high. And out of those, we know that about 400 million will have moderate to severe sleep apnea. So it is really big and the incidence is high. So this is all on this Lancet paper. And what I'd like to bring it over here is that really with an AHI here greater than 15, that's the 425 millions that I said. But if we count just for the mild cases, that goes even beyond. So do we need to treat them all, or who are these people? So first, to start, I'd like to bring one thing. Yes, obesity is high. And yes, many times the appliance doesn't work that well with patients with obesity. But what we know is that even for patients with BMI less than 25 or being normal weight, there is a high prevalence of mild, moderate, and severe sleep apnea. And yes, it is less in women, but for men over 50, even if they are non-obese, there's going to be about 20% of them who will have mild sleep apnea at least. So what are we doing and how are we going to do with all of these people? Of course, I think first of all is not CPAP for everyone. I don't think we are quite that naive anymore to think that's the whole future. We are learning a lot more, and I think a lot of the things that we've been talking about is really trying to go back to genetics. Is there something we can better understand? Is there something we can change? But then really, what can we understand more in terms of the endotype? You know, as Dr. Wen just said, how is the function from this patient? Is that something different beyond what we used to think? It's not pure anatomy. We know it is not pure anatomy. It goes far beyond that. So pure or mostly anatomy is going to be only about 40-45% of the patients. But also then there is the phenotyping, is because we know some people will be there and they have no symptoms at all. You just go because, yes, the wife heard there was just a snoring, person perfectly fine and has no other issues. And that's great. While we do have some other ones with very mild sleep apnea and overly symptomatic. So those patients also sometimes with insomnia related to it. Or if that is a mild patient with major other cardiovascular diseases, do we treat them the same? So I think all of that is coming and we're getting this, trying to tailor what is going to be coming next. What shall we do? So it's not as simplistic as we would think of. So I really would like to talk about this, and this is an easy reading article, I'll say, if you want to go a little bit more in depth about this physiology part, which I find the first few times that I was reading them a little daunting, and it is hard to do. So this is, I did that part of it when I was in Australia with Peter Sistuli, Kate Sutherland, and Philip Chazal. And it is really talking a little bit about this prediction of, and how can we predict from the diagnosis to comorbidities to the treatments. So it involves everything. So it has to go beyond. It has to look, of course, different risk factors and different people, which can come from the neural control or ventilatory control, but we have to see the clinical expression for each and every one from them, go into what are the physiology features. And again, this is where, for example, as a woman, I'm always interested in this part. We know more and more that there is a higher tendency for women to have a high REM AHI, and because of that, their overall AHI gets lower, but maybe the risk is the same as if we could look only at the specific REM AHI for women. So there are a lot of nuances there that we need to understand. And going beyond the AHI too, what is just the AHI, but what is the person who's desatting into the 80s? It is different than a person who have mainly hypopneas with very marginal drops in the oxygen and never goes below 90%. So those are things that we have to start going beyond the pure AHI and the CPAP, and that solves the word. So definitely what we need to understand. Of course, when we talk about all the other morbidities, the main thing that we have looked at is, okay, CPAP doesn't save people. It doesn't seem like we are really curing people and not letting people die. And that's the things that are coming out right now. But what if the person already has hypertension? What if the person already have atrial fibrillation or other things? What is that person is at a genetic predisposition for being more susceptible for those hypoxic burdens and so on? And that's where we're going. And that's where we need to learn more. It's not one size fits all when we talk about sleep apnea. So I'd like to start with the mild cases, and that's a little bit, as I said, it has affected us here in BC with insurance, which our insurance doesn't cover treatment for any mild cases at all anymore. So it is a little bit of an issue right now, but it is important for us to understand. It came a lot of some of the articles. I was very fortunate to be in this one work that was published in the Blue Journal in 2016, where we evaluated the whole literature about what are the really consequences, or what are the improvements of offering treatment for mild cases. And what I'm going to talk about is this one is more of an opinion from Walter McNicholas, which is a very well-known and extremely experienced clinician in the field of sleep apnea. And what he looks at it, and he was really pointing out in terms of how do we divide now this mild cases into different types here. So there are the obese ones, and the patients also with poor sleep habits. You shouldn't give the person a CPAP or even an appliance, but you should try to change the lifestyle measures. If you see a person who has purely supine dependent sleep apnea, you should start right away with positional therapy. If there is a person now with predominant snoring, and if that's an issue, the oral appliance would be a great thing. But now if there is a lot of sleepiness, then they call it a CPAP trial. Just they know this is a trial, but not treatment. So the correctable, of course, if there are some major anatomical other things, that should be surgically approved. Of course, they pointed out there are new pharmacological things that can be done in the future. But what do we know about what is this CPAP trial? What we know in terms of CPAP for mild cases, the adherence is really, really poor. So anything around 15%. So they proposed the oral appliance, or the CPAP in this case, as a diagnostic pathway. And why is that important? Because sleepiness is something that we see in a lot of other things. It is not just sleep apnea. So if we have, for example, irritable bowel syndrome, one of the main things is sleepiness. If you have arthritis, you're going to have sleepiness. If you have asthma, you're going to have sleepiness, and so on and so forth. So there are a lot of other things that we have to think about that will go beyond that. So they pointed out, try the CPAP first. And if you can improve those symptoms are likely caused by the sleep fragmentation. That was caused by the sleep sleep apnea per se. Okay, so they said to try it for about 2 months, and if it's really a patient can say, well, first I always say, you know, if you have definitely managed to use the CPAP too, because a lot of patients get even more fragmentation by using the CPAP. But if you could use the CPAP for even a few nights and say those nights were amazing, I woke up the next day, I had so much energy. So then you should treat those patients because their sleepiness is due to the breathing issues. But what about the other side? Okay, so one of the things is, okay, I diagnosed mainly the mild cases, and I'm saying now if the person is symptomatic, you should treat. And I think that's where we should go beyond. We should start when the patient comes to you, not understand only is it mild, moderate, severe, but it is this patient mildly symptomatic, moderately symptomatic, or heavily symptomatic. And that's where we should understand more. We should face, especially when we talk about the clusters, and I really like this one article talking about really the treatment effects on the different clusters here. So the clusters are mainly the sleepy cluster, the patients with insomnia, the patients that are asymptomatic, for example. So I think those are important. So we need to reclassify our patients, not just the AHI, but the symptom types and qualities of those. And what do we know in terms of those symptom subtypes? And for example, the incidence of cardiovascular disease. And this is just a little quick touch on the subject is much, much deeper than this. But what we know in here is just kind of a survival probability with time of new incidents of cardiovascular disease. And you can see here the orange line being the excessively sleepy patients. So these are the ones who will tend to die more. Okay, or to have more cardiovascular problems, mainly if they're sleepy. It's not AHI related, but we're talking symptomatically related. Not to say that AHI is not important. Yes, it is, as it is the oxygen burden, but it goes beyond. We have to start looking beyond that. So now focusing onto oral appliance and where is the future here? I'd like to start with this piece of evidence that we have with CAD, and this is important for us Canadians here. So CAD stands for Canadian Agency for Drugs and Technologies in Health. So it is actually from the government, but it is not completely linked to the government. So it is actually a group of physicians and researchers who look at the field, but they are actually not interested in the field because they are not the physicians that are going to sell CPAP. They're not going to be the ones treating. So they don't have the same bias that you and I have that think this is the most important things. They are really arm's length from our field, and they look at the evidence and they come with guidelines for the Canadian healthcare decision makers, which are normally healthcare providers and the government per se. Okay, so what do they say about sleep apnea? So this is a little summary from what they said. So again, following what I said from Walter McNicholas is that with mild cases, again, you would say there should be no treatment or really like weight loss, exercises, or more behavioral therapies. But now if you're moderate to severe, you should be doing CPAP or the appliance. And here for severe cases, offering maybe maxillomandibular advancement surgery, not any other surgery. So that was the only surgery that was there. But now how to choose? Okay, so they pointed out the considerations that we should have when choosing the treatment for sleep apnea. And I was so happy to see that first time ever, there was this main word here, which is patient preference. Okay, that's something we have to understand. We have to think about what does the patient want? What does the patient prefer? And does the patient have, for example, running water? Can the patient plug it in? Does the patient knows how's their health status? Does the small bite changes matter? Does the cost matter for that patient? So those things are definitely coming in place. So of course, I don't have to say what oral appliances are. We are in this field, but I think we have to go beyond that. Okay, first of all, why? So I think there are some things that we are not, again, just the one thing that is perfect there, because the appliance is also, though it's the adherence is amazing, it is great, is not perfect. And we know right away that the adherence is about 85% right from the beginning, and it will tend to drop down with the years, especially sometimes coming with side effects. This is a very nice review that just came out this year, and try to understand, okay, how can we say who are the ones who are going to adhere the most to oral appliance? A lot of the things that I was sure this is likely one of the issues, but we saw first, for example, age, sex, obesity, AHI, and even daytime sleepiness. they were not strong predictors of adherence. So it's not because the patient is sleepy that it's going to use more or less. It's not because the person has a small mandible or a narrow palate that the person is going to use the appliance or not. It's really, they looked at other polysomnography parameters and not correlated. So those things are definitely very important that we saw. Some predictors, though, and this is first one, is a negative predictor. Is actually if the patient is already a CPAP intolerant or non-adherent, that person is more likely not to adhere to oral appliance. Okay, so which means, and we know that from many other fields in medicine, that if a person doesn't really adhere to one therapy, they're more likely not to adhere to other therapies as well. But then what are the other things too is we know side effects, and that's one area at least that we can act on. And the main thing is that if there are a lot of side effects right in the beginning, they're going to be more likely to discontinue. So that's when our follow-ups need to be acting quite fast. And there's some papers as well from that we published from Australia showing the initial 20 days are crucial for us to solve those side effects. And it is the same thing for CPAP. But finally, what was a positive predictor was actually patient preference, acceptance to treatment, and some patients' behaviors. So those are really, really important, and the patient's perception of treatment benefits. So if the bed partner was satisfied, if the patient felt they were feeling better, that would definitely improve what was going on. And what do we know about those preferences? And this is a really nice article from Japan that showed that a lot of things, if any of those things kind of being more important for the patients, such as being simple to put it in and take it out, as being the comfortable appliance. If it needs something, if you know what, I'm afraid that my partner will not be accepting this or not. There are a lot of things that oral appliances are definitely seems to be better than the CPAP. So patients overall feel, more tending towards the appliance, also because they feel that both of them work the same when they can use either or. So CPAP and the appliance, in terms of a lot of the improvements such as sleepiness, snoring, and refreshed sleep, they were the same. So really this adherence is really hard to understand, but I think patients will selectively decide which treatment they want and if they want to continue with therapy. Of course, I think for us, especially is the long-term adherence is the dental side effects, and we need to work a little bit more on those. But we still have the other thing here that we have in terms of adherence and efficacy. Really, we need both. We cannot just fully be on one or the other one. So even if the patient is great and adhere to the appliance, if it doesn't work well, the patient should be going on to CPAP. So what do we do here? One of the things I like to point out, which we talk a lot about, is this mean disease alleviation, or the SARA index, or this effective AHI. So we're putting in together in one formula the AHI together with the adherence. And what I like about this EAHI is that it will talk about the hours the patient would be on CPAP divided by their total sleep duration times the AHI on treatment, but they also will take away the time that the patient is not using any treatment and almost going back to the original AHI. So here would be 5 hours a night with an AHI of 4 and 3 hours a night with an AHI of 40 for a patient with a baseline AHI of 40. So this EAHI for this patient is 17. So this is closer to what we normally say about this residual apneas for patients with oral appliance, even though they use all night long. And this could be more of a truly effective AHI in CPAP cases. So this is where it's driving us to start thinking a little bit beyond and really start looking more to personalized healthcare and what we talk about P4 medicine systems. And let me go a little bit onto those. So this is not something new. This is already described back from 1986, where there were some main core principles when you're really doing this patient-centered medicine. And it is quite interesting that the number one here that we never think much about in our field is respect patients' values, preference, and express needs. So when I talk about express needs, is that patients don't come and say, I need to have an AHI of less than 5. They may come and say, I need my wife back in my room because the snoring is all I care. And you need to understand that. Okay, so we need to have this coordinated and integrated care because they may actually need the CPAP beyond that. We need to have more communication, but they can only do some of those decisions if they are educated and they know everything that is going on. And of course, there are a few other things. In this one paper from Jacques and Hilbert, they did point out trying to apply those things into sleep apnea per se. And of course, we have to think about patient preferences. There are some ways of going through this with decision aids, which is a work that Nelly and I are just finalizing right now. And hopefully we're going to bring you some results with decision aids, but really trying to get, and something it is, Nelly again said it for the pediatric groups, and it is the same thing for adults. We have to have multidisciplinary care teams. And what about those? So it's just patients jumping from here to that. Is that just the appliance versus CPAP? And I think this was a commentary really from Robert Thomas based on the one article here from Shruti, where was talking about this fixation that we have on these unimodal approaches for sleep apnea, which he actually says that it defies biological reality. So I think we have more and more evidence in sleep apnea that we have all these phenotypes and these endotypes. And right now, we still haven't really applied them, and it hasn't really come yet to patient care. This was 2012, and I would say maybe we are not there yet either. So I think the main thing that we have so little data on combination therapy was likely the CPAP efficacy, but we have to think more about that. We need to improve the management strategies. And mainly why? Because we know that it's about 50% compliance for CPAP. And what he pointed out, if 50% compliance is the gold standard treatment, so maybe the gold is a medal of a lesser worth. Okay. So combination therapy, what do we know? I like to start to say maybe what not to do. And these are some things that is mainly me, and everyone who knows me knows I'm very opinionated about some things. So sorry if I'm going to be a little firm in some of the things here, and I may take it back. I don't mind that. As soon as evidence comes, I'm happy with that. But I think, dentistry have sometimes been the little garbage bin from things that didn't work in medicine. Pharyngoscopy, that we were trying to predict oral appliance effect, and they tried to push into dental sleep medicine at all costs. It is out of it. CBCT again, and can you evaluate that? It's an static message. The CBCT was first developed mostly for medicine, but the accuracy for a lot of the things were so poor that we were the only ones who could actually digest and have some value for it. Not that it doesn't have value, it does, but not in dental sleep medicine. Sorry, I do not believe we have something in there. And the newest kid in the block now is the laser. And really, when I looked at the data, the lasers has been out there since the 90s, the late 90s. And so far, no good research data has come out of that. And now it is dentistry, and they're selling it to dentists. So for we to be buying this thing that didn't work for anyone else, and there's no data. It may work in the future, but not now. I think there are lots of treatments available, for example, CPAP, the appliance, and beyond that, what are the other ones? We can't forget exercises and training. No one that goes to a physician with high blood pressure will tell the person not to exercise and not to decrease in the salt intake. You have to do those. So you have to keep on adding. And we know those are very effective as well. We know, for example, for CPAP and weight loss, even just the CPAP on its own doesn't help. Okay, so when you had the weight loss together with the CPAP, there was an incremental reduction in insulin resistance and triglycerides. Okay, so you have to combine the two, just not the sole therapy. So we have to understand that also in terms of adherence, it helps even more. Okay, so you have to get the combination of the two. Okay, so it's not easy to maintain weight loss by all means, but it has to be done in combination. Exercising training, it has shown to again decrease AHI by about half. And it's not just a little bit. If you want to get more into that, and I always tell my patients, if you're already exercising, try to do more of the cardio exercise. Try to do more, on going on an elliptical, try to really run, or if you just walk, try to take the hills. So your heart rate is going to go up, and that would be very important. So they say about 50 minutes, but at least 40 minutes with aerobic exercise 4 days a week. And again, it is a great improvement in overall quality of life, but as well in the AHI per se. Why not do both? And I think that's very, very important. Like they just did with CPAP, studies with CPAP and weight loss, oral appliance and weight loss, oral appliance and exercise. We need to do those. For hypoglossal nerve stimulation, I think we all have seen a lot of those. But again, so this is a nice literature review, but they are a lot of other things. They do not completely solve the problems. And there has been one small study with patients under DICE. And you can see here just with mandibular advancement splint, the reduction. This would be just with some stimulation here, the genioglossus, not the same of the hypoglossal nerve stimulation that we're talking about, but if we add both. So of course, if you're acting on now, as Nelly was saying, on the function of the tongue, plus adding the anatomical space for the tongue, this is likely a good treatment approach. Oral appliances after UPP, I think we haven't done UPP for quite a while, but now they're getting more evidence again, and when to prescribe and to whom to prescribe, and they know the efficacy has been much greater. And now we also have, recent studies trying to show it's actually very good to add the appliance for those cases that have apneas again. Another point that I'd like just to make, and there's no data on this, but we all know about modafinil or modafinils. It has been widely used in patients who still have sleepiness after CPAP. But they never get to be prescribed with appliances. And they say, oh, it's because you still have residual apneas. Well, even then, I think if the patient cannot tolerate CPAP, still have residual AHI, why not prescribe them for oral appliances as well? So I think there is a need for further studies as well to look into that. I'd like to touch a little bit on positional therapy. There is the night balance that is really well known. It's now been sold by Philips, and I'm happy to know that Canada is now allowed to sell the night balance. There are a few other little options. This is the Smart Nora pillow. It will sense the snoring here, and the pillow starts to move, so the patient can move the head and move around. So seems to be fairly useful with no studies. But just looking at really just the traditional more combination therapy, like the one from Philips here, we know that adding the body position therapy together with mandibular devices, there is a very good improvement in the AHI beyond that any of those separately. So we need to understand. And of course, the only thing we have to think is that adherence is still higher with positional therapy than with the appliance. And again, choosing one more treatment, why not? You can add CPAP and the appliance. This is an old study showing there is a nice decrease in the pressure of CPAP by adding the CPAP with the appliance. So patients who cannot tolerate high pressure of CPAP, they could go to the combination of those. But what about the interface? This is a study that we're almost about publishing it in the JDSM, being connected or not connected, and we talked a little bit about those. And what we found, it was actually no difference, but by being connected versus disconnected. And actually maybe having it disconnected would give us some more flexibility. You can add some oral appliances where you can add a little valve like the EPAP, and you could put it on top of the appliance. Again, we can be creative in those. And this one study, they actually just looked at patients who were not successfully treated with mandibular advancement splints, and they added this extra layer, and they simply increased a lot the success rates. Okay, so those things are important for us to keep an eye on, and this is likely going to be the future. But more than all of them is, of course, this one work between Nelly and I, where we do look at this treatment. And it was mainly looking at, okay, patients when they feel the same with either treatment. And when we looked at one study that we had done, just offered the appliance for patients who were already on CPAP, the Epworth went even lower. And we didn't quite understand, but actually patients were then going more days without any treatment, even though the appliance was not perfect. Okay, so what we thought is that the patient could be doing every week differently. Like for the first week, he used CPAP on Monday or appliance on Tuesday, then maybe 3 days in a row for the CPAP, and then the appliance on the weekends, and so on and so forth. So could the patients go on a daily basis choosing which treatment do they want? So this was what we have used. The initial part is a traditional crossover phase where the patients will be for 1 month on the CPAP or the appliance and crossing over with a washout period. But this is when we disclose the treatment outcomes and we told the patients what were the main results, and they took both treatments home. What we found, and this is just the beginning of the sample, that we had the majority of the patients with more than 70% of usage of both. So I'm saying here now that 52% of the patients would be using some kind of a combination. Some were either on our appliance only or only on CPAP only, but now we have the majority of the patients being really well treated or adherent to treatment. When we looked at Epworth, for example, and FOSC, we know that independent of going into this modality of going back and forth between the treatments, we still managed to keep them quite with low sleepiness and really good quality of life. As well, in terms of fatigue, you can see here from initial, they came down and they were really keeping those low. So very, very good. And in terms of adherence, again, this is 1 month in the combination. This is after 6 months into the combination, either by the percentage of nights of device use or the mean hours used. We can see really patients now under treatment after 6 months being over 6 hours of treatment use. So it's very, very important. So advantages, again, your higher percentage of time on treatment. There's less burden of both therapies. We are really looking at patients' participations, and we know that increases patients' effectiveness. And our majority of our patients were willing to pay out of pocket for the second therapy as well. So I think it is time for us to understand better all patients' preferences and to understand the role of combination therapies. We cannot do this alone. It's going to be more and more multidisciplinary integrated clinics that we need to go for, and we need to think about this personalized health. So yes, we still have a long way to go. We have a lot of research to do, and this is why Nelly and I are here and trying to do a lot of the studies that we can. So, and finally, we just have to say that yes, appliances are there. They're not the most as effective as CPAP, but they are great for all levels of severity. And we need to have treatment planning that involves and values patients' participations, and especially because we have this chronic disease. And most of all, I'd like to congratulate you all that are here, because I do believe that we will only achieve this with dentists who are highly trained in this field. So thank you for spending an hour in a day for a beautiful game that is already starting and being here to be with us. So thank you all, and I'll be open for questions.